we have the man building. Okay, I don't know what's going on over here. So start. We have to construct a timeline. When you start, I'm telling you about orthognathic surgery. So when you look back all the articles, we obviously the main article, the main publication is about technique description. I mean, all this scientific publication, the authors try to tell us how to perform orthognathic surgery. So the article is pretty technical. So we are coming this until 1980s. So this publication over here, I think is the timeline, you know, the pretty wall that divide the old and new ones articles, you know. So over here we are kind of description about techniques, and in 1980s Dr. Epker, so he tried to mix surgical skills, surgical oral maxillofacial surgery, and try to get in orthodontics knowing about this. So when he obviously when he tried to mix these great areas in dentistry, so he tried to tell us, okay, we need to know a little bit more about jaw correction. So when you saw articles later, you know, the quality of the articles is we gain a little bit in quality. So we try to discuss about stability. We try to discuss about conceptual things about orthognathic surgery. So this is the article that, I mean, is the greatest thing that we have in orthognathic surgery, the article of stability. So this article tells us about what's the procedure, what's the movement is more stable. So about this, we try to create concepts about orthognathic surgery. So over this, we try, okay, we have to do a little bit more stuff in the orthognathic surgery to reach good deals, you know, about this. So forward of this, you know, we try to I mean to move, you know, and try to what can I say? We try to change the concept, you know, so about the facial planning. So right now we need to construct, you know, about your diagnosis. So here we're discussing about some topics about occlusal plane alteration. So where I go around the world, so all doctors discuss about occlusal plane alteration, but you know, until now I have great doubts about this dual maxillary occlusal plane or maxillary dual occlusal plane. This is a great thing. So this is lead us to different diagnosis and different treatment about jaw correction, minimal invasive orthognathic surgery, and digital planning. So the last one, I think, is the most newest technique that we try to figure it out how it works. In my point of view, if you don't know how to handle all the softwares of digital plan, I think you are you're out of the the specialty. So which occlusal plane is more appropriate to alter? We don't know. So we have at least 3 occlusal planes, So which one is more appropriate? It's a question. So and my ask is depends because we have occlusal, we have maxillary occlusal plane, from the lower the tip of the upper incisor. Mandibular, it's the tip of the the tip of the upper incisor, the maxillary. The mandibular, the tip of the lower incisor, and the functional is the bisector of these ones. So you have the bisector angle. You're construct the functional. So which one are you like to use? So my question is aleatory your choice? I don't know. So choosing the functional plane, the patient with especially the deep bite frequently has both an excessive curve of speed in the lower arch and the reverse curve of speed in the upper arch. Choosing the advanced mandible, choosing to advance the mandible along the functional occlusal plane will mean the orthodonts will have to level both upper and lower arch by introducing the anterior teeth. When you do this, when you advance, you make a counter, you make a clockwise rotation. So we need to know this kind of choice of choose of this occlusal plane make us an aesthetic standpoint. So when you choose the other ones, clearly the patient with deep bite has 2 different molar incisor occlusal planes, one for maxillary and one for mandibular incisor. And the one for mandibular, if the mandible is to be advanced along these divergent planes, the distal mandible must first be rotated. I mean, rotate clockwise so that the planes coincide before advancing. When is it done? The teeth are advanced more than the pogonio, and the lower face height is increased. So the occlusal planes tell us about the aesthetics changing about these 3 occlusal planes. So what's the right angulation, or the right what is the perfect occlusal plane? If you go backward, so the literature tell us if you wanna try to construct the maxillary occlusal plane, we have to work on 80 to 12 degrees. That's the perfect occlusal plane. Dr. Wolfing, in his article in 1993, he advocated that occlusal plane is 8 degrees plus minus 4. It's 4 to 12. But in this article, he didn't mean us what kind of occlusal plane it is advocated to work. So we don't know. So if you don't know the occlusal plane, I think, and I advocate that you use the maxillary, because this more this occlusal plane is more stability. Does not has action about the mandibular rotation, so it's more stable when compared with other occlusal plane. So here we are having maxillary dual occlusal plane. What is it? what is it maxillary occlusal plane? We are fine when we have open bite. This is a great challenge in jaw correction. So the surgery of jaw correct produce profound effects on facial cosmetics. And we have most carefully considered the effects of any skeletal manipulation. The same occlusal result with the minor modification of the maxillary plane can have dramatic consequence on facial balance in both horizontal and vertical dimensions. So it's imperative that our coronary reconstructive surgery fully understand to do the manipulate the handle of the all the occlusal planes. So when we have dual occlusal plane, we need to know the specific etiology of maxillary dual occlusal plane. So we have a little concerns about this. So in our diagnosis, I think it's the most common open bite that we have. So until now, when we faced with this kind of problem, we should know that the conventional orthodontics doesn't apply this. You know, right now you should work with segmental wires to correct this, and the support of orthognathic surgery is gonna solve all this problem that we have when we have dual occlusal plane. Why I'm asking this? Because if you use conventional techniques, conventional orthodontics techniques, we are trying to solve this. We are trying to fix this only by extrusion teeth. So, and we have, when we saw the literature, the specialty literature, we know that it's a kind of unstable movement in correction of open bite. Okay, so when we have dual occlusal plane, maxillary dual occlusal plane, so we have this part over here, the posterior segment in a ideal position, and anterior procedure in an anterior segment located more superiorly. So what's the treatment? What's the treatment when we have this? I think this kind of problem over here, we have only one treatment that we apply: surgery. Because if you want to try to solve this using conventional techniques, you're gonna be a relapse of all of this treatment, you know, because this kind of movement to close the open bite, the orthodont movement to close the open bite is pretty unstable, and the relapse is gonna be in 6 to 12 months after your treatment. So obviously we have some cosmetic effects on this. So all this I think is the most cosmetic effects on this. I think is the on the prenasal area. You know, when you put down all the anterior maxilla, you're gonna provide the nose base, and you can put the tip of the nose a little bit more forward. When we have posterior segment inferior, okay, right now this part is broken, and this one is I'm telling you, it's okay. Over here it's broken. What are we gonna do? So again, we have in this type of dual occlusal plane, we have two types of treatment over here. So when we have TADs, when we have transitional anchorage device, so we can apply this over here and intrude all this teeth over here and correct the dual occlusal plane. Okay, but you have to do surgically of this. Yeah, you can do surgically. I don't know if it's more appropriate. I think right now you're gonna hear the patient, and you're trying to explain the pros and cons of these two treatments. So right now we know a new concepts. We know a new try to solve. We have TADs to try to help us on to fix this kind of problem. So this right now we have the posterior segment in the inferior position and the anterior segment in ideal. So what's the treatment? We have two treatment right now. You can go to the surgery and we can go to orthodontics, but not the conventional techniques. We have use TADs to fix over here. So this is I'm trying a little bit that a kind of thing that I'm explaining you. So why we apply the conventional ortho techniques? Because when you apply this conventional orthodontics techniques, we are trying to it's a try to overrupt it this teeth. So, and we know that kind of movement is very unstable. So over here, when we saw this kind of patient, we must know it's a kind of the mantra. You must know that you only used class 1 mechanics. If you want to try to use class 2 or class 3 mechanics to fix this, we're gonna go to the way that we are certainly going to the relapse when we try to close this bite. So the surgery is gonna provide and is gonna reallocate all the bone segments in the ideal position. Guys, minimal invasive orthognathic surgery. It's a pretty it's a new vanguard, and all guys are the publications around the world is it's a lot of them. And right now, if you do conventional approach, okay, you're dead. If you do the newest approach, okay, you're a celebrity. So I have some concerns about minimal invasive orthodontic surgery. Of course, we have to move on, to keep walking. So, but we have to know that we have a learning curve. So we don't have to go like crazy, like a crazy dog, when you have this conventional techniques and this newest approach. So I think right now we are the social media is leading us to the way that we cannot go back. So we have to think a little bit more about this. We have we have where we where we're staying and when we have to go. So what's the difference between conventional approach and the newest approach? We're gonna discuss. So when you go to the articles, the authors tell us only the advantage about minimal invasive orthognathic surgery. So short incisions, oh, that's pretty good. That's perfect. So we are gonna make short incisions, and we do all the procedure. But my question is, can you do orthognathic surgery with short incision? Is it right? Is it correct? I don't know. So I have at least 20 years that I'm treating patients with dental facial deformities. So, and I construct my learning curve about my experience. So right now, I think I cannot see how to treat patients with minimal incisions. So we can decrease. Obviously, your surgical skills is improving a little bit day by day. So so we don't know. Minimal detachment. Okay, if you have small incisions, short incisions, so the detachment, the stripping of the tissue, it's a little bit more less than the conventional one. So fast procedure, if you no, all of this is a consequence, and less blood bleeding. So okay, it's awesome. This it's a perfect technique. So what's the problem with minimally invasive orthognathic surgery? The problem is when you saw the literature, Tron and Obvigazer, the first described technique of BSSRO, it's like this. When we saw the articles that advocate minimally invasive surgery, the technique is pretty the same. My question is, we are come back to the history, or we are only trying to make some different? I don't know. If you look this technique and this for me it's the same and the same. And the Dr. Epker, when he published his classical work in 1977, he tells us about at least five things that we have to look. Another thing that we have in minimal invasive orthognathic surgery is, okay, so we have small incisions, we have small osteotomies. So if you do not perform the bilateral sagittal split ray osteotomies, okay, we are doing the mandible fracture. So when you do the mandible fracture, you have to keep in mind your nerve, inferior velar nerve, still remain at the proximal segment. So when you reallocate the distal segment, we are put the mandible in a new position, and the proximal segment is still located at the primary position. So this movement, you can cause a nerve stretching. For me, it's a disaster when you have a problem in orthognathic surgery. Once the greatest things that bilateral sagittal split ramus sternum tell us it's okay. The nerve you have to keep in the distal segment. Why we have to maintain this nerve in the distal segment, because we have the nerve is gonna be reallocated with the distal segment, and we are right now we are preserve the integrity of the nerve. So we have to take a look on this miracles technique. So okay, we are again we have to moving forward, but we don't forget the biology. Okay, I mean, oh, crazy. You don't forget the biology. And finally, we have the digital planning. So the digital planning is it's a new technique. It's a wonderful old guys like me try to relearning about to why we handle computers. So computers for us in the past, it's only to make our lectures and and get into the internet and buy stuff. So right now, computers have another and new a new thing to do. So this apply and try to help us on the facial planning, on the facial orthognathic diagnosis. So if you don't handle, if you don't know to um, how to work with softwares, you're pretty out, So right now, but if you don't know the biology, if you don't know the concept, okay, the software don't make all the stuff for you. You have to tell the software what's good, what do you have. So the software is a pretty stupid. So right now, the software is a kind of tool that help you to make your cases a little bit more easy. So right now we have the case. We are composite maxilla and a composite mandible. So here is a profile the profile and new front view, the profile view and the front view. So right now, this patient we planning about three-piece for one, and we osteotomy between 3 and 4. So the software, it's tell us and prevent us about the problem that we have in the surgery. So is it very good, very very awesome, and we can show all of this to the patient, but carefully. So right now, you have to know about some stuff that the software lead us, and we have to know about us. The software, this is for me, this is the minimal invasive surgery. When we have digital tools, we have newest tools when applied to conventional techniques. So right now, if you construct the cut guide, when we construct the stuff like this, the things like this, you can make small incisions. We can prevent bleeding. You can prevent all this stuff. So here we can prevent the nerve damage. Because why we prevent? Because we can't see when are doing the facial, the digital planning. So this is very, very cool stuff to do this. So if you want, you can do it all the osteotomies that you want to do. So here it's a little example that that we are doing over here. and obviously you have to know how to maneuver the software. So it's not easy, it's not cheap, but you have to. So this is this is the most problem that we have. So the software is not the software is not the major thing that you have to know something about your basically anatomic things, you know. So what's the difference between this intermediate guide and this one? What's the difference? Because this guy, okay, I'm gonna do the intermediate guide, okay, aleatory, okay. So what over here, we know that the teeth has angles, and the guide has, you know, X of insertion. When you try to insert a stuff like this in a teeth that has angulation, we have X axis insertion, guide of insertion. So over here, if you don't know this, you're gonna make this kind of problem in your orthognathic surgery, in your procedure. So this is I think this is the worst problem. So that's the problem that we need to know, that we have to solve, and only a surgeon like us are able to know this kind of thing. Guys, doesn't matter how many resources do you have. If you doesn't know how to use, it won't be enough. You never know how to use, you know. So thank you to be here. Question and comments. Thank you, and I'd like to apologize for my broken English. You know, it's sometimes it's hard to us Latin guys like us. It's